Good afternoon, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, Marketing Specialist, and I'll be your moderator. This is part 5 of our 6-part webinar series focusing on treating patients with disabilities. If you missed parts 1 through 4 and you would like to rewatch them, please email webinars@henryschein.com and we will get you the recordings. We're excited to welcome back Dr. Maureen Perry as our speaker today, as she will discuss intellectual disabilities featuring Down syndrome. Dr. Perry is the professor of special care dentistry and the director of the Center of Advanced Oral Health at the Arizona School of Dentistry. In addition, Dr. Perry is a fellow of the Academy of Dentistry for Persons with Disabilities and is a diplomat of the American Board of Special Care Dentistry. Before we get started, we have a few reminders for you. At any point during today's webinar, we do encourage your participation through the chat and Q&A features. Please type any questions you might have into the Q&A section of your control panel, and we'll answer them live at the end of the presentation. Directly following today's webinar, we're asking that you complete a quick survey to let us know what you thought of today's presentation. If you elected to receive CE credit for this webinar, it's required that you complete this survey in order to get your CE certificate. It's also required that you attend this webinar for the entire duration. Your CE certificate will then be emailed to the email address provided during registration, and your account will be billed within 1 to 2 weeks of today's date. Henry Schein is only able to offer CE credits to doctors licensed and practicing in the United States. If there are any questions about CE for this webinar, please email us again at webinars@henryschein.com. All right, Dr. Perry, the floor is yours.
Okay, thanks so much, Adam. So today we're going to talk about intellectual disabilities, or ID, and mostly we're going to talk about Down syndrome. The second webinar really featured a lot on intellectual disability and the treatment, dental treatment and dental management. So I encourage you to go back and maybe listen to that one if this is your jam, if you're really interested in working with this population. This is my disclosure. Again, CE. And here is your information. Adam went over that. But again, for live attendance, you can get 1 CE credit. You will be billed within 1 to 2 weeks. You have to watch the entire webinar. You have to do the questionnaire, and it's only for doctors who are licensed and practicing in the U.S. If you have questions, please email them to webinars@henryschein.com. Learning objectives: define intellectual disability, list the common features of Down syndrome, and describe behavior management techniques. So we've talked about this before, but for those who might be new to the series, developmental disability basically encompasses 4 main disabilities, and that's autism, cerebral palsy, epilepsy, and intellectual disability. Today, we're going to focus on ID, intellectual disability. So what is it? It's a disability that's characterized by significant limitations in intellectual functioning and in adaptive behavior, and it covers everyday social and practical skills. So it has to happen to become developmentally disabled. It has to be while you're developing, so before you are an adult. And this is a kind of an old chart, but it still rings true that most people with intellectual disability are in the range of mild, between 50 and 70 IQ, which means they're like a 6th grader. I think most practicing dentists and hygienists and assistants can treat somebody who's a 6th grader. So that's like the large majority of patients. And those are folks who have social and vocational skills and really need very little self-support. You know, they can really do their own thing. Then we have folks who are in the moderate range. That's about 10% of people. They're like 2nd graders. And then we have some folks who are very severe. And those folks, of course, would need the most support. What are the causes of ID? Fetal alcohol syndrome, genetic and chromosomal conditions such as Down syndrome or Fragile X, infections. And honestly, there's more than 800 documented syndromes that are associated with intellectual disability. Down syndrome is the most common one, and that's what we're going to talk about today. So here's the background. In 1865, it was first described by Dr. John Langdon Down, and it was based on physical findings, things that he saw in patients. In 1956, it was discovered that human DNA has 46 chromosomes. And then in 1959, it was discovered that the disorder is based on an extra chromosome. So that is why it's called Trisomy 21. So the etiology, again, It's non-disjunction of the 21 chromosome during either oogenesis or spermatogenesis, and 95% of the time, it's just plain trisomy. There's 3 separate copies, and these are original pictures that were taken and preserved by Dr. Down. So you can see them there from in the 1860s, 1870s of people with Down syndrome. Sometimes it's caused by translocation. That's pretty rare. It's only about 3% of the time. And that's when there's an extra piece or a whole chromosome 21, but usually it gets attached or translocated onto another chromosome. So it's sort of hanging on. There's also cases of mosaic Down syndrome where only some of the patient's cells have 3 copies of chromosome 21, but other have 2 copies of chromosome 21. And this is probably in the folks that we see who really do extremely well academically and really have very little, if any at all, intellectual disability. It's likely, and it's been postulated, that those folks probably have a mosaic form. What's the prevalence? Well, in 2002, and I looked this up today, so I can tell you, this is sadly the latest statistics that the CDC has is 2008. So there was a lot more people alive in the U.S. You can see just from 2002 to 2008, it went from 83,000 to 250,000. We know that the prevalence of Down syndrome is affected by the mother's age. So the older the mother gets, the more likely it is that a child will be born with Down syndrome. However, most of the kids who are born with Down syndrome today are born to women who are under 35, so women who are not considered high risk and therefore might not be getting and might not be getting prenatal testing. Life expectancy has greatly risen in patients with Down syndrome. It's now around 60. And down there on the right-hand corner, you can see that nice young man. He is, in that picture, he's 78. I have 2 patients. One is 67 and one is 68. So those are the oldest patients that I personally am treating with Down syndrome. And then now the National Down Syndrome Society actually has a whole bunch of stuff about aging and Down syndrome, which, even 15 years ago, people with Down syndrome only lived to their 40s. So pretty amazing. Let's take a look at these 2 spectacular young ladies.
When Isabel and Abigail were born and diagnosed with Down syndrome, it was a start of a journey for everyone, for Matt and for Jodie. Their odds are 2 million to 1 that they'd both be diagnosed with Down syndrome. And they had nowhere to go. They were ploughing a new path. So the launch of Twincest, the idea was to raise awareness about Down syndrome and change some of the perceptions that exist around Down syndrome. All the best things that happen to Matt and Jodie happen because of their children. And the point they're trying to make is, listen, if your kid gets diagnosed with Down syndrome, it's not some sort of death sentence. It's nothing to be worried about. And they're talking about their highs and the lows. And Abigail and Isabel, great kids. And they have so much fun. And the purpose of Twincest isn't to ram home this message, to people about Down syndrome. It's just to say, look, these are the facts. If you want both sides of the story, we'll give our side of the story. And they'll do it with a smile on their faces. And if you met Abigail and Isabel, that's all they've got, smiles on their faces.
Well, my sisters are cute and they like watching TV with me. We go to Puddletown Pirates sometimes, and sometimes we go to the Space Centre and we play with each other so we can make friends with other people. I don't know what Down syndrome is.
I think the biggest barrier is growing up, because you look in the playground with the girls and everybody they're just Abigail and Isabel. There's no difference. I don't know where that line is or what age it becomes where there starts to be those negative thoughts, because I had them. When the girls had the diagnosis, I had the negativity. But the kids in the playground don't, the kids at nursery don't. At what age does that, and if I could do something about that, then I would.
For me, I know it probably seems a bit strange, but there's absolutely no difference. I'm the same with the girls as I am with Finley or I'm with my own kids. I've got Ellie and Ben, and there's no difference. In fact, they give more cuddles.
These signs, some people might not understand some of the signs, but there's nothing. They're just both normal girls that like to play.
we cried, and I sit and I wonder, what did we cry for? Why did we cry? The fact that we've got twins is a lot harder work than the fact that we've got a child with Down syndrome, let alone two. It always comes down to the fact that there's two of them, the fact that they've got Down syndrome. And I would love to this day to go and ask that doctor, what exactly were you sorry for? Because I'm definitely not sorry.
You can see Isabella and Abigail. They're the only known identical twins with Down syndrome, and they have their own YouTube channel, and they have a foundation called Twincest. So you can go online and find them. They have lots and lots of videos. They like to ham it up. They're super cute. So there you go, talking a little bit with the family and the mom and seeing the girls in action. So what are some of the physical findings and medical conditions? Well, an interesting thing that you'll see in the palms of kids with Down syndrome is they have what's called the simian crease. Their crease goes all the way across their hand. And that's one of the very common things that you might see. So here is one of my patients. He is here. He's about 17. So I don't know how much more he's going to grow, but you can see some of the physical findings there. Short stature, and he's a little bit chubby, and you can see he has that midface hypoplasia. He has low set ears, down slanting palpebral fissures, and epicanthal folds you can see in his eyes. So that's one of the things. So here we see all of the physical findings. So talk about patients might also have congenital heart defects. It's important to know if that heart defect is a cyanotic heart defect. If it is a cyanotic heart defect, you have to find out whether it's been repaired or not. And then you can determine whether that patient might need coverage for SBE, right? Might need antibiotic prophylaxis. People with Down syndrome have impaired immunity. They have an impaired neutrophil function. And that leads to things like increase in leukemia, increase in periodontal disease. Also, many have hypothyroidism. Airway anomalies are common. And Atlanto-Axial Instability. We're going to talk a little bit about that. Atlanto-Axial Instability is important when it comes to doing things like either holding a patient's head, or the other thing that it might be is when you are going to intubate a patient. So you have to know, because if they do have that, you need to get a C-spine series of x-rays to determine if they have Atlanto-Axial Instability. And if they do, you certainly don't want to tilt the patient's head all the way back. Talked a little bit about leukemia. Incidence might be up to 50 times higher than that of the general population. These are folks, obviously, that you need to talk with the hematologist, you need a CBC, you need other tests as needed, depending on what you're doing with the patient. Upper respiratory tract infections is a greater incidence than in the general population. It has to do with the immunologic deficit. And it's the second leading cause of death in patients with Down syndrome after cardiac abnormalities. And I love this little guy right here, because you can see really that sort of open mouth posture and the tongue laying over the lower teeth. Again, we talk about Atlanto-Axial Instability, and you can see here, just to remind yourselves, that's right at the base of the skull. And if there's ligament laxity there, the patient can, even you really head tilt chin lift, really aggressively, you can actually paralyze the patient. So you have to be very, very careful with that. Obviously, if you're going to give somebody with Down syndrome CPR, you want to do a jaw thrust. Okay. They often have patients will often have dry skin. It's easily irritated. So you can see that maybe around the nose and mouth. You look at the eyes, they're always almond shaped, inward slanting. You have, again, epicanthal folds. They have an increased risk of cataracts, and you might see strabismus or nystagmus, and that's pretty common. You might see eye abnormalities. Again, often, as we say, it's an intellectual disability. It's a developmental delay. So people may have delayed speech. They may have a husky voice quality, low set ears, often small, and you can see that in this young lady here. Pardon me. That's often, you see that in a lot of syndromes, low set ears. Helix is often flat or absent, and they have a high incidence of hearing impairment. One of the issues with the hearing impairment that is often discussed and postulated is that because They have midface hypoplasia, that the eustachian tubes don't drop and are like as they are when they're in babies, which is sort of horizontal, and that they don't ever tilt down. And that may actually be a reason that we get hearing impairment in these patients. Some of the behavioral considerations we have to think about. So patients who have an intellectual disability, it may take them longer to learn to speak. These folks have some anxiety. They may have some repetitive or obsessive and compulsive behaviors. They have some oppositional or impulsive or inattentive behaviors. Many have sleep-related difficulties. They don't sleep well, and that may also be related to obstructive sleep apnea due to the midface hypoplasia. And the patient lays back, and then they have a large tongue. And so a lot of patients suffer from OSA. Depression, you can have autism as well as Down syndrome. So we see that in patients. And they can have neuropsychological problems by progressive loss of cognitive skills. As patients get older, patients with Down syndrome, when we look at autopsies of patients with Down syndrome, we see amyloid plaques just like we do with patients in Alzheimer's. And we know that people with Down syndrome get Alzheimer's early. Of course, we didn't see this before because they didn't live long enough to get it, but you may see this in patients in their early 50s. Sometimes we see it in patients even in their 40s developing Alzheimer's symptoms. So here's some famous people. They're all actors, and you might recognize Zach from the Peanut Butter Falcon, or Chris Burke from his long-running TV show, and Lauren Potter. So again, you see similar facial characteristics. We also see sinus abnormalities. So folks have lots of sinus issues. They might have absent sinuses or reduced maxillary sinuses, and that may also account for their difference in their voice. And they may also have nasal septum and conchal deviations. So other issues why patients might not breathe so well, and also adding to the OSA. We see lots of cleft palate. Many times it's repaired, but even when it's repaired, a lot of times we see like a high vaulted palate, which makes it pretty difficult to make dentures, make an upper denture. We see relative macroglossia, right? So small mouth and large tongue, or just large tongue. There's been some studies on this, probably small mouth, and that makes the tongue look really big. Small palate, decreased arch length and arch circumference, and a fissured tongue. So these are some of the things that we might see in patients with Down syndrome. Talked about that midface hypoplasia. So a flat, broad nasal bridge, no supraorbital ridges, and eyes really close together, right? So hypoteral. So we can often see that in patients. As far as mandibular positioning is, a lot of times we see a mandibular protrusion, an open mouth posture. And again, this is because when the child is developing, the midface doesn't develop fully, and that makes you look like you are protruding. You have a protruding mandible, but really you probably don't have much of a maxilla or premaxilla. Here's some famous people with Down syndrome, some athletes. The fella in the middle is the only person with Down syndrome to complete an Ironman triathlon, so competing against people without Down syndrome. The fellow on the upper right is an MMA fighter. He actually sued to be included in the MMA. They weren't going to let him fight because he had Down syndrome, so he fights against people who do not have Down syndrome. He's a professional fighter. The young lady with the golf club, she actually lives here in Arizona, where I live, and she is on the local college golf team. She's an outstanding golfer, and she's on her college golf team. Then we have a power lifter, a guy, he actually powerlifts for college, and a gymnast. So these are folks who are athletes in their own right. And I'm not talking about Special Olympics. These are folks who are just, they're athletes. So kind of amazing group of people. What kind of oral findings do we see? Well, we see maxillary hypoplasia. We see lots of malocclusion. They may have anomalies in tooth number and morphology, lots of missing laterals, lots of increase in periodontal disease. Again, that has to do with the neutrophil deficiency, macroglossia. And then we also see things like toroodontism and peg-shaped teeth, ectopic eruption, and gingival inflammation. So malocclusion, mostly class 3, but we also see lots of cross bites, and we do also see open bite. So this is one of the biggest problems, is patients actually functioning with their malocclusion. We see microdontia, so patients have little tiny teeth, and we see short crowns, and we see short club-shaped roots. We see toroodontism. We see little mulberry molars. We often see peg molars for the third molars. We also see these like microdontia, little tiny molars. And you can see them here in this radiograph. You can see that this patient has some microdontia, little tiny molars and an impacted tooth, and it's actually transposed. And then we see primary teeth without successors. So all of these things you can see: over-retained primary teeth, delayed eruption, impacted teeth, and microdontia. And so we see a lot of different things. And you can see some of these things or all of them in one patient. Other things we see, again, missing laterals, a lot of missing laterals, and varied tooth morphology. We also see people with excessive spacing. So they are missing teeth, right? And they have hypodontia, and then they end up having a lot of spacing. This is really challenging from a prosthodontic standpoint. And that's the biggest challenge you have with folks with Down syndrome, is trying to figure out what is the best prosthetic option for folks. We often see really advanced periodontal disease. You can see here in this x-ray, somebody with really advanced periodontal disease. The thing that's really interesting is you'll often see patients who on x-ray really have terrible periodontal disease and a lot of bone loss, and you'll see minimal mobility. And this is sort of interesting, and you don't really see it in other populations. I always think it's being held in. I'm like, is that tooth being held in by like 3 Sharpies fibers? I don't know. But I will tell you this, that I will maintain teeth in patients with Down syndrome that I don't think will be able to replace prosthetically for much longer than I will with patients who don't have Down syndrome. And if the patient can tell me that they're having pain or they can complain, I'm willing to let them go. If they're functioning with those teeth, I might leave them there. Particularly lower anteriors, because they're very hard to replace because of the tongue positioning and the open mouth posture. It's really difficult to replace those and keep them in there and keep a patient comfortable. So sometimes, you just document it really well and say the patient's functioning and we're going to leave them there. They're not as mobile as you think. So about 90% of people with Down syndrome have periodontal disease. It's sort of the inevitable. We start to see bone loss when they're young. We see early onset, and it doesn't really have to do with the plaque virulence. There's lots of studies on this. It's just because they have a decreased immune response and this ligamentous laxity and rapid degeneration because of the neutrophil defect. So while we want our patients to have nice, unlike the patient in these photos, we would prefer that the patient, besides their class 3, was brushing their teeth. So again, you still have to have hygiene. That's super, super important. But it's rigorous perio treatment they're still going to be refractory. Many patients will not respond to this. And that's because it's genetic, right? We also see a higher incidence of ANUG, that punched out gingiva. The thing is that sometimes patients don't complain about it. Unlike teenagers who get ANUG, that, they kind of have that, what I always think of as like dragon breath. It's like, you can really smell it. It doesn't smell as bad. And patients don't complain about the pain like they do for kids without Down syndrome. So important thing to be aware of because it does need to be treated. Oral hygiene concerns. So sometimes we see poor oral hygiene, and that's really mostly due to compliance. The studies show that basically it doesn't really matter if the patient lives in a group home or at home, or at home or in an institution. Oral hygiene concerns are there. Some of it has to do with the fact that these folks have lots of malocclusions, and it's kind of difficult to brush. It's difficult to floss. And then it might not be the highest on their priority list. So again, talking with parents, talking with caregivers, talking with patients about what needs to be done and how we need to keep up our oral hygiene. Perio disease, yeah, you can be pretty aggressive. You can try surgical approaches. There's mixed reviews of that in the literature. I don't really do that anymore personally because it hasn't been real successful. The patients still end up with refractory periodontal disease. So we just really try and keep the patient clean and do our best and really get the patient to buy into a 3-month recall. Dental caries rate, some of the literature says it's lower than other groups, and then some of it says it's not. Here's what I can tell you about that, is that patients often have buccal caries. We see a lot of buccal caries because the patient has an open mouth posture and they get dry mouth, and then we see smooth surface caries. Most of tooth loss that we see in patients with Down syndrome has to do with periodontal disease and not necessarily caries, but obviously patients can get caries. Again, we talked about the prosthodontic considerations and how difficult that is. And when I'm trying to decide what I'm going to do with any of my patients, I think about the patient cooperation. I think about, am I doing this for the patient? Am I doing it for the parent? Who is going to benefit from this and whose life is going to be improved? So this is a young man. He was in his 20s. He came in. You can see he's missing teeth. He's got a lot of spacing. He's got some primary teeth. And one of our restorative dentists said, "No, I think I can do this. I think I can build a house on this." And he was actually able to go ahead and make some fixed bridge work on these teeth. The patient did really well, and he kind of changed his whole attitude. The patient was kind of being bossed around by his mom a lot, and he got a lot more confident, and he acted like an adult once he had his teeth. He was like, really took charge of his life, and so it was very rewarding. This was a really good case. But again, these are not easy cases. He's a pretty high functioning guy. He wanted to get his teeth fixed, and he was willing to go through the treatment. So again, case selection is everything, just like every other patient. This is a big movement that's going on. Lots and lots of professional models with Down syndrome. And you can see people here on the cover of Elle and Allure and Glamour. And these are not folks who are modeling because they have Down syndrome. They're modeling despite the fact that they have Down syndrome. So they're not, they're just modeling like everyone else. And many of these folks have been on the runways in Paris and New York and Milan. And so it's pretty cool. Many of them, obviously they're all professional models. This is what they do for a living, and lots of interesting websites, and you can go and check them out. But again, models from all over the world here in these photographs. Let's talk about dental management of folks with intellectual disabilities. On the right, there's a guy, he's a painter, and he actually is at one of the Langdon Down institutes. There's an art institute in South America that's sponsored by the Langdon Down Foundation, and they do art exhibits, and he's one of their artists in residence. So when we're going to treat patients, any patient with an intellectual disability, everybody's an individual. Like, what's the patient like? What do they not like? What is their goal? What would they like to have done? We use a lot of tell, show, do. We do a lot of very simple things, positive reinforcement. You're doing great. Yeah, great job. I always tell my patients they're doing great, whether they are or not, right? Nobody likes to get yelled at. Everybody wants to know that they're doing well. They need to do a little better. Ask them to do a little better, whatever it is they need. Many of our patients we've seen so long, and they're happy to see us, and they like to see me, but they always want to see the dental assistants. They're always like, where's Miss Kathy? And where's Miss Karen? They always want to see them because, of course, they see them a lot more. They see the hygienist more, Karen and Ellen, and they see them more, and they want to see them. And then if they have a favorite student at the university, they say, where's my student? Lots of folks want to, kind of like their sameness, like everybody does. So you need to talk with who does the person live with? Get the background. Caregivers are a great resource. They'll tell you about past dental experiences, successful behavioral strategies, calming influence during treatment. And obviously, if the patient can tell you these things, you ask the patient. And there we see a picture of Jamie Fox, his sister Deandra, who unfortunately has passed away, but he is still a big advocate for the Global Down Syndrome Foundation. Let's see. Things people with Down syndrome are tired of hearing. Let's listen.
Because you never know what might come out of the house.
Like, what is Down syndrome, Bella's saying?
What makes you angry?
Smoking. Nigel Farage.
You don't like him?
Not in the slightest.
People with Down syndrome can't have relationships.
Well, obviously they can have relationships.
Kissing is my favourite pastime,
Yeah.
I reckon.
So you're really romantic.
Oh, so romantic.
Yeah.
I like William Hague and George Osborne and Justin Bieber. Not David Cameron though.
People with Down syndrome can't learn. Yeah. All right then.
Yeah.
Yes, they can. Maybe sometimes they might need a little bit of a push.
Yep.
I've got qualification in customer service, qualification in hairdressing.
I passed all 10 of my GCSEs.
People with Down syndrome are just normal people.
You know, will she be able to do this? Will she be able to do that? And I say, yeah, she'll be able to do everything. It's just we'll take the scenic route.
This is our pet hate. Adults with Down syndrome are like children.
Oh. Do you ever have people like come up to you and talk to you like you're a child?
Yes, it's patronising.
Yeah.
But some people do the head tilt as well.
Oh, bless her. Isn't she lovely? How old is she? Infantilisation, do one.
Yes, please.
Some people say it's a disease. It's not.
No.
Down syndrome is a condition which is caused by an extra chromosome.
Doesn't stop you from doing anything, does it?
Well, exactly.
We bring something different to the world that other people can't.
People sometimes do come out with words like Down syndrome sufferer. The only thing I suffer from is bad attitudes.
Those with Down syndrome can't live independently.
I hope not. Of course they can, because I live independently.
Hopefully wanting to live with my boyfriend.
Wouldn't mind living somewhere with my girlfriend as well.
And have a life and go out with friends and having a nightlife as well.
I get my ensuite back if you move out.
So you want me to move out today?
No.
Those with Down syndrome can't have jobs.
Well, that's wrong.
Of course they can.
Yeah, of course they can.
Yeah.
I've had so many different jobs.
I work in a hair salon and I love it.
Yeah. Went through retail, office work, went back to retail and then went back to office work and then media.
I'm also an actor as well.
I got a job as an actor and a dancer.
You're famous one day, Tommy.
Yeah, well, even more.
One day I might be put in EastEnders.
You never know. But she can be anything she wants to be. Well, unless she wants to play for Liverpool, in which case...
It's quite upsetting to hear about something like that.
But it was 90% of people were getting rid of it because they found out they were Down syndrome, and I thought, that's shocking.
Some people call this Down syndrome serious handicaps, but it's not.
Babies with Down syndrome can be aborted at 40 weeks.
I've heard of that.
Whereas a baby without Down syndrome, obviously the cut-off point is 24 weeks. So I think there's an ethical question there.
Because we can all lead amazingly active lives, can't we?
Yeah.
She doesn't like the testing.
Do you wish you didn't have Down syndrome?
No. Why? It's just me, it's part of me.
I may have Down syndrome, but without it, I don't think I'd really be me.
I don't wish that. I wish that people will see Down syndrome in a positive light.
My motto in life is Down syndrome, so what?
There you can see a group of young adults and some older adults talking about their life with Down syndrome. And I put that in there to give you some perspective and to bring to the point that, you always talk to the patient. You don't talk to the person who drove them there or their mom or their dad or whoever else is with them. You always speak to your patient. If you have to then explain it to someone, you explain it to whoever's with them. But obviously your relationship should always be with your patient. And talking about engaging your patient, talking to patients about whatever they like. One of the girls said she works in a hair salon. One of the other girls is an actor. The other girl had a lot of different jobs, worked in media. So, what do you do for a living? What do you do during the day? And what are the kinds of things that you like to do? For kids, ask them about school, just like other patients. Obviously, consistency of care is important. And I would say that everybody likes that. Nobody likes to go to the dentist and get there and find out that it's a new hygienist who's going to see you, or a new dentist, or, oh my goodness, they got new dental assistants, right? Everybody likes consistency. And some people like to go the same date and time. They might like to sit in the same operatory. A lot of us like sameness. I think it makes people feel comfortable and safe. Positive reinforcement, and we talked about this in other lights about each step, telling people what's going to happen, tell them what's going to happen now, this is what's going to happen at the next visit, and not surprising anyone. One of the things that's really interesting in seating patients in the chair is telling patients with Down syndrome the chair is going to move. There's this interesting phenomenon with patients with Down syndrome where when you move the chair back, they sort of jump like they didn't know it was going to happen. They seem very, very sensitive to motion. And this has been reported anecdotally in the literature, although no one can explain why. It may have something to do with their balance and their station tubes not dropping, and the midface hypoplasia as a cause of that, that their balance is a little off, because patients, you don't see this in other patients with intellectual disability. They sort of like grab the chair and they get nervous when the chair is getting going to recline. So I always try to distract patients, but I tell them the chair is going to go back, and I expect that they might jump a little bit. Controlling patient movement, not letting patients move all over the place or have unexpected, movements because they didn't know there was going to be noise or vibration or water. Obviously, if you have to create a patient's head, you might have to and control patient movement. You have to be careful that you don't ever compromise somebody's airway. And, you have to be trained in protective stabilization. So you should never try and restrain someone or stabilize them if you are not trained and you don't know how to do it safely. So here's some different kinds of mouth props. Obviously, if you need to keep somebody open for a long time, they work great. We use them a lot in endo. Sometimes the surgeons use them, but we use them pretty often so that patients are comfortable, and you don't have to keep saying, okay, open wide, open wide, open wide. We do sometimes use a Papoose Wrap. We talked about this extensively in seminar number 2 and the webinar number 2. We don't use it really too often unless we have an emergency and we have to see what's going on with the patient. We do have a few patients who do better in it, mostly patients with autism. I can't think of any patients with Down syndrome that we use this for. Obviously, sometimes patients might need to be sedated. They might have, like our young man that I showed that has that kind of big case. You might just have a really big treatment protocol, or somebody who really is pretty impaired and can't really cooperate, doesn't understand the goals of treatment, right? So they can't really cooperate. A lot of times I'll always try nitrous first, least invasive, and that's often sufficient. Even using nitrous oxide and halcyon is often sufficient, just some anxiolysis. We do have an anesthesiologist, so we can do conscious sedation or IV sedation or even general anesthesia. The problem with sedating patients who have Down syndrome is they're often kind of obese. They often have OSA, and they have Atlanto-Axial Instability. So they're not my favorite people to sedate because of those reasons. The anesthesiologist isn't always a big fan either. Not an easy intubation. A lot of tongue there, a lot of midface, not so easy. So we're very careful about who we sedate, and so not always the person I want to do a sedation case on. We're going to talk here a little bit about some of the most successful people who have Down syndrome, and we'll just give you a little taste of it.
People with Down syndrome are not always fully embraced by society. But fortunately, there have been people with this disability that became very successful. In this video, we're going to look at 10 of the most successful people with Down syndrome. Number 1. Colette DeVito. Colette DeVito was treated unfairly because despite finishing a 3-year cooking course at Clemson University in just 2 years, she was rejected at every job interview. Colette was still persistent, took her most popular recipe, the Amazing Cookie, and founded Colette's Cookies. At first, she was working with a single grocery store, then gradually built up her client base, raising her profile with media appearances on CNN, MSNBC, CBS, GMA, BBC, and more. This led to her having a partnership with Lay's Potato Chips too. Colette now employs 13 people and hopes to use her platform to reduce unemployment and poverty levels among people with disabilities. Number 2. Marty Wexelson Goksar. Marty Wexelson Goksar is a public speaker and disability activist, but she is most well known for her work as a writer. Her most famous work is her interpretation of Cinderella, which is based on her own life. She performed this at one of Oslo's most prestigious theaters and features live music from the Noughties pop band Hello Goodbye. Goksar's work made her the first woman to win the Bjørnson Prize from the Norwegian Academy of Literature and Freedom of Expression, and her version of Cinderella was even used as the basis of a scientific study that examined the differences in attitudes towards disabled actors between children and adults. Number 3. Angela Bachelor. Angela Bachelor started her political career in 2011 when she began working at City Hall in the Spanish city of Valladolid. Bachelor spent a little over 2 years working as an administrative assistant in City Hall before standing for election in 2011. Although Bachelor did not win a seat in that election, she assumed office 2 years later when a corruption scandal forced Jesus Garcia Galvin to step down. Number 4. Jamie Brewer. Jamie Brewer is an actor that many of you may recognize from recurring roles in the American Horror Story series. Having worked in theater for over a decade, Brewer skyrocketed to international fame when she made her TV debut portraying Adelaide Langdon.
So I'm not going to show all that. You guys can look it up on it's actually on YouTube, and you can see 10 of the most successful folks. And some of the people that are on there is John's Crazy Socks. In case you've never heard of them, that is a guy. He's really like a sock king. He is built a $1 million sock business with his dad. And he has Down syndrome, and you can buy those socks. They're available online. That shows many artists and actors, designers, and a woman who is a swimmer. She was the first person with Down syndrome to actually swim across the English Channel. So many inspiring people that, quite frankly, can do stuff that I totally cannot do. So very interesting and inspiring. And I encourage you to look that video up. I'm going to show you now a case of a young man. This is a patient of mine, and I do have permission to show it from his mom. He's been with us for a few years. So you can see this is in 2018, in the beginning of 2018. So 3 years we've been working with him. And you see when he first came in that he has some teeth that are not quite in the right place. We're missing a lateral. We've got primary teeth still there. We've got blocked out teeth. We've got lots of teeth that we've got spacing. We've got a lot of orthodontic problems here. And when I asked him, what do you want? And he said, I want to look like a movie star. I said, okay, well, that's going to take some time, because we're going to, it's going to take us a long time with your teeth. You're already a handsome fellow, but it's going to take us a long time with your teeth. So, in doing orthodontics in patients with Down syndrome is really a challenge, because you can't move things really fast. You've got to move them pretty slow. Those short conical roots, if you move the teeth too fast, you won't have any roots at all. So you have to be really, really careful. And so if you are an orthodontist, you may know that already. If you're referring to an orthodontist, and for a general practitioner, make sure that you know that this orthodontist has treated patients with Down syndrome and has the ability and the knowledge to do this. So here you can see we've got a really deep bite. He's got a lot of overjet, and we've got a lot of issues here. So here you can see in his ceph and his pano. So we see, again, we see a little bit of toroodontism, but what we do see is impacted canines, right? And we see some turned laterals, and we see some over-retained primary teeth. So part of the issue here is he's 14 here, so he shouldn't obviously have primary teeth. So that's an issue. The other issue we always have to look at with patients with Down syndrome, because of the midface hypoplasia, we often see impacted canines. Very, very, very important. Can't stress it enough. If you have a patient with Down syndrome, take a Panorex when the child is 5 or 6. Like, as soon as those 6-year molars come in, get a Panorex, count your teeth, see what kind of space you have. Maybe a good time, if you're unsure about your spacing, send the patient to an orthodontist for a consult. Like, let's look at this, because you might want to do serial extractions, because orthodontics, you don't want to be in orthodontics for 3 or 4 or 5 years. So again, you may consider, what teeth should we take out to get the canines in? And again, these are cases that, we didn't see this young man until he was 14. I wish I had seen him much younger, and then we might have been able to do some phase 1 interceptive work and some serial extractions, and not have to be doing so much ortho for so long. So here we are uncovering things and putting our gold chain on, and you can see that the canine's on the palate. Not my favorite place for it to be, but you can see us putting in some orthodontic appliances and trying to make that canine come in. Obviously, you can see there's a patient sedated here. He is not an obese patient. He's a pretty small guy. And for this surgery, we actually had to do a nasal intubation, which is not that easy on patients with midface hypoplasia, but our anesthesiologist was able to do it. So here he is at the top at 16. And you can see we've made some space, and things we've made some space on the lower, and things are getting a little bit better. We were unable to actually bring in that canine. And we finally decided not to try it. He was playing with the chain a lot. The chain kept breaking. We kept having to uncover the soft tissue and put the chain back on. So we decided against that. He did well with the rest of it. He just didn't really like the chain, which is kind of interesting, because he's had braces on for over 3 years and he's doing just fine. But you can see the spacing. And the plan now is to make enough spacing for us to then do the restorative with some implants. Now, the thing that's so interesting about that is, should you use implants or not? There's some literature that will tell you that putting implants in with Down syndrome patients are likely to fail. Now, those were patients in the study. It's a retrospective study. And in that study, when they looked at this, it was patients who had lost teeth due to periodontal disease. And I would say that if you're whenever you're putting in implants because somebody lost their teeth to periodontal disease, you have a higher incidence of implant failure anyway, right? But this is a patient who actually has very good bone and is very young. So when he stops growing, we will put some implants in, and hopefully we'll have all of our spacing made by then, and we'll be able to restore him. The plan right now is that we are going to try to move that primary canine and give us enough space for an implant. And if we can't, then we're going to have to try and make that canine look like a permanent tooth. So still trying to see how things are going very slowly. Teeth aren't moving as quickly. And of course, we have to move them slowly in this case. So lots of references for this one. Again, for your CE information, one CE credit for today's attendance. Your account will be billed in 1 to 2 weeks. You have to watch the whole webinar. You have to complete the questionnaire, and CE is only for dentists licensed and practicing in the US. If you have questions, you can email at webinars@henryschein.com. Our next session Autism, What's New, What's True will be Wednesday, April 21st at 6 o'clock Eastern. There's your registration right there in the little box. Again, I guess, Adam, I will toss it back to you and I will take questions.
Great, thank you. Let's see. We've got a couple minutes here for questions, so if you haven't, drop them in the chat or Q&A. There was one comment earlier that said, I find that patients with Down syndrome tend to have a gag reflex that's more sensitive. Do you find that to be correct?
I do. And I think part of that is because they have such a big tongue. And it's like every time you do something, you touch their tongue. I have tried sitting patients up. Of course, we've tried using some Sedation spray and things like that. I basically try not to pay attention when patients gag too much. If they're going to gag, I let them gag, I let them cough. I don't tell them not to do that. That tends to make them do it. And you also kind of have to figure out, is this an avoidance mechanism or is it real? I find the gagging is mostly real, and it can be pretty difficult to get x-rays. A lot of times I use pediatric, size sensors to try and get x-rays. And again, of course, you want to take that Panorex early and make sure that you count the teeth and look to see that, especially for impacted canines.
Do patients with Down syndrome often have posterior tongue ties?
I haven't seen more tongue ties in patients with Down syndrome, and I haven't seen that reported in the literature. But it can happen. It can happen with anybody. But their macroglossia and having those restricted arches really does make it more difficult for the patient to articulate. And certainly if they had a tongue tie, I would treat it.
We got a comment that said, I've found nitrous helps with gagging.
I found nitrous helps with gagging too. And if you can get the patient to accept, wearing the nitrous, then it seems to work well. I use it a lot in the clinic. I use it with patients with Down syndrome often. Anybody who's got any kind of dental anxiety that understands the goal of treatment. So if the patient understands, like, okay, I just have to relax a little, those are the patients that do pretty well with nitrous. If the patient doesn't know what you're doing or can't comprehend it, patients are often kind of feeling, they feel like a little suffocated, or they don't really understand, the goal of treatment. So you always kind of have to make sure that your patient understands when you're going to use nitrous.
Did the premolars erupt on their own after you removed the over-retained primary molars in the case that you showed, or did you have to use a chain to bring them into the arch?
The premolars came in very slowly. It's like we just kept waiting and waiting, and then they peeked through. It just, because they were over-retained and the premolars had full root formation because he was 14. There's no impetus for them to come in. So it just takes a little bit longer. And they started to come in on their own. And we decided, because we'd had the incident with the chain and the canine, that we weren't going to try and drag them in. So we let them come in, and they did take a long time. Again, I can't stress enough how important it is to get that Panorex early and see what's going on. Because if we were able to take those teeth out when he still had root formation, before he had full root formation on those premolars, then obviously they would have come in a lot faster. So, this is a kind of a cautionary tale, that case.
Can you use palatal expanders to correct posterior crossbite?
Oh yeah, you want to throw in the palatal expander. So yes, you can. But understanding that, basically I don't know about your patients. I never had a patient who's like, wow, thanks for giving me a palatal expander. I really loved it. They're really uncomfortable until it splits. Until the suture splits, they're uncomfortable. But we do have patients that with Down syndrome that we have used them. Again, it's a cooperation situation with anyone with an intellectual disability. And I'm going to tell you that I'm not, even after 30 years, I'm not really good at figuring out who's going to be cooperative and who's not. So a lot of times I'll say to the parent, or the guardian, let's try it. We can always just take the braces off. Like, if you're willing to try it, I'm willing to try it. Again, with the palatal expander, yeah. And I've seen many cases that they'll, in the literature, and we have done it. You have to beware of relapse. These are folks who relapse a lot because of that hypoplasia, and so you've got to figure out how you're going to maintain that. Once you get your palate, once you get those cusps locked, you're okay. But if you're doing this in mixed dentition, you've got to really be careful, and you've got to leave it in there a long time so that it maintains the arch and you don't get relapse.
I got a great question here. Do parents want us to treat the children the same as others, or do they like us to point out what we see that is different and how we can help?
That's interesting. I don't know, because I don't know all parents, but I would say this. I treat everybody with a disability the same way I treat everyone else. I just treat people with dignity and respect. And I might say to the patient, to the parent, I'll say, listen, it's not unusual. Like if I see impacted canines or if I see over-retained teeth, I'll tell them, this is not unusual. We often see this in children with Down syndrome, and this is how we treat it. It's not a judgmental thing. It's like, this is the fact. This happens with this syndrome, and this is how we fix it.
Do you have any other tips for behavior control short of sedation?
I like to distract patients. I like to let them listen to music. I wear crazy socks, not always John's, but I wear socks and always silly socks in the clinic. And I'm always like, I use that in one of my distraction techniques. I'm like, hey, have you seen my socks today? And all the kids and my patients with intellectual disabilities are often like, can I see your socks? Like, Dr. Perry, let me look at your socks. So that's my thing. But I often will try to get the patient to cooperate with me. And if I can get a little bit of cooperation, I'm gonna try. I'm not going to sedate anybody unless I've tried other methods. Again, I do it a long time. We use tell, show, do. We try to make people feel comfortable. We don't want people to feel judged. We want them to feel safe and accepted. And people with intellectual disabilities are like kids and small dogs. I always tell people, they know if you're afraid. They know if you're uncomfortable. So, you kind of have to meet the person where they're at. They're just a person. There's nothing to be afraid of. You can't catch it. It's like, just be cool about it, treat the patient like you treat everyone else, all your other patients, and see how they react to you. Give people more time. It's going to take them longer to get used to what you're doing, to figure out where, that you're not going to hurt them. Now, of course, people who have a severe intellectual disability are never going to cognitively be able to cooperate with you because they don't know what you're doing and they may be very fearful. And those are patients that may have to be sedated. But as I said in the very beginning, about 85% of people with intellectual disability are not people who are going to need sedation. It's a very small group of people.
For Down syndrome patients with, I'm going to screw up this word, Atlanto-Axial Instability, what can you do to avoid cervical injury during treatment?
Yeah. So, you just don't want to do the head tilt chin lift thing. You just don't want to jam their head back. If an anesthesiologist is going to intubate them, they'll know not to do that. Okay. They'll put a pillow back there and they won't tilt. They'll use a scope. Most of them are going to use a scope that has a camera. And, you want somebody who's going to sedate your patients that has sedated people with Down syndrome before. Because it's the anatomy is a little bit different and they're harder to intubate.
Have you had any success with laser-assisted periodontal therapy?
I would say that we have tried it. And again, we've tried it on patients with Down syndrome and without Down syndrome. I haven't seen personally, and this is completely anecdotal, any better results with that than I have with non-laser assisted. However, again, it's not the pathogens here. It's the fact that they don't have good attachment because of the neutrophil deficiency. I haven't seen any studies on that. I think it would be a good study to look at in this population. It's very hard to get any kind of data on this population because they're a protected class, right? So when you go to do an IRB at the university and say, I really, the institutional review board, and you say, well, I really would like to take a look at these patients. It's pretty hard to get that through because children and pregnant women, they're just a protected class of patients. And And so you have to really do doing clinical studies is not the easiest.
All right. And then our last question here. At what point do you or might you decide to refer a patient to a special patient clinic?
Oh, well, I personally, the buck stops with us. Like, I don't have anywhere to send them. so we see everybody, as the residents and the students say. Like, I say no to nothing. I'm like, okay, if I can't see you, we'll figure out if we have to sedate you in a hospital. But I think if with any patient, if you are not comfortable as the provider and you feel like, you know what, this is beyond me. This is not my wheelhouse. I'm out of my comfort zone. Then I think you should refer. I think if it's like, I don't have a lot of experience with this, and I think it's fine. It's just like, I don't have a lot of experience doing, sinus lifts. So I'm going to send you to the periodontist. I don't have a lot of experience treating a patient with Down syndrome who's got this malocclusion that needs to go to the orthodontist. I'm not comfortable with that. Now, the thing is, it can't be because you're not personally comfortable, right? Because you don't want to discriminate against anyone. It has to be because you don't have the skill set. And the question is, well, if somebody really needs to be sedated, well, then you might not have the skill set. If you feel that you can't do the dental case, you just haven't done any cases, like I showed the young man who needed like a roundhouse, and somebody in the community who does, then I think it's fine to say, I'm not a prosthodontist. I'm not sure I can do this case, but let me send you somewhere else. And I think, I think that's okay. If you're sending someone because you don't have the dental skills and it's beyond what you can do, that's fine. But you can't send somebody someplace just because you don't want to treat someone who has a disability, right? It's illegal and unethical.
Great. Thank you for that. As a reminder, if you did elect to receive CE credit for today's webinar, it's required that you complete the survey upon exiting. Your account will be billed within 1 to 2 weeks of today, so please be patient as we process your CE. I'd like to thank Dr. Perry, as always, for sharing her time with us today and presenting. And of course, thanks to all of you for attending. If you have questions regarding CE or anything covered in this webinar series, please email us at webinars@henryschein.com. We look forward to seeing you back here for our final topic in part 6 in April. Have a good night, everyone.
Bye-bye.